what other advancements do you see coming? You know,
I mean, we're looking.
Or in sort of curing, or
Yeah, I mean, it's going to be a slow process. I think one of the reasons is that what we call GBM now, what we used to call just astrocytoma, has been split into really 4 different subtypes, right? Well, I think in the future, probably GBMs will then be split into further subtypes depending on their receptors and whatnot. I mean, one of the things that has been in the medical literature is called MGMT, methylation promoter. And some of those, the promoter actually makes a tumor more susceptible to some of the chemotherapeutic agents. Those are the things that are constantly being discovered. And so we want to take diagnostic advances, like, you know, in terms of this is pathologic. So in MGMT, we also send out for MGMT on every single patient. So taking these kind of diagnostic markers, is, for example, pathology, MGMT, then coupling that with newer chemotherapies, you know, we're stretching out survival. I mean, maybe it'll become someday like prostate cancer, where patients don't die from the disease, but they die with the disease. I mean, Joe Torre, for example, has prostate cancer. But it's something that can be, right now, can be controlled, and patients kind of just live with it. Hopefully, perhaps someday, now I know this may be very, very far off, okay, because astrocytoma is such a deadly disease. But it's got to start somewhere.
but you're just speaking of glioblastomas.
Well, any astrocytoma, yeah. But I mean, the GBMs are the most poor prognostic entity out there. But yes, any one of those astrocytomas, we want to be able to, you know, continue to lengthen out the survival times, and eventually maybe come up with a cure.
Do they actually give a survival time? Because I know it's changed so much, but do they say? Can you say?
Do we say, no, because like, we can only go by statistics. All right, and even statistics aren't even, obviously they're not right. There's a bell curve. There's a bell curve for every single statistic, right? So I don't know. The patient that I showed you with no enhancement along the margins, maybe the next follow-up scan will have some enhancement. That may be turned into real progression. You know, I just can't say.
It's crazy, isn't it?
It is. The other thing about GBMs and, you know, any astrocytoma is that, you know, there are tumor cells that are throughout the brain. So any area that wasn't enhancing, you can take out the area that was enhancing, but there may be another area that will pop up. And it has to do with genetics. Whether that a cell on the other side of the brain decides, hey, you know, I don't like following the rules anymore. I don't like being a grade 2. I'm going to upgrade myself to grade 3. Then eventually grade 3 is going to upgrade itself to grade 4. I think one of the reasons my mom survived for 2.5 years, even on the older chemotherapy, is that it was really confined to the one area. If another area, and I'm sure there was tumor cells there, if another area on the other side of her brain had decided I'm going to upgrade myself, there's no way she would have survived for 2.5 years.
I read something about one of the advances about the dye that's placed in during surgery, and the surgeons could actually perform surgery and under a fluorescent light, and they could actually show individual cells that are cancerous if they highlight with the dye. So that seems pretty promising.
Right, so we're looking into dyes that can do that. I mean, on the imaging, on the radiology side of it, there's what's called molecular imaging. So tumors all have receptors to them. There's these, and each of these receptors may be unique for a particular type of tumor. Or in a patient's body, maybe that the tumor there has a specific, let's just call it an XYZ receptor. And then so if we can target that receptor, both diagnostically and treatment-wise, you know, then you can really focus in all of your treatment efforts into just attacking that tumor. That's the ideal. I just want to quickly use thyroid cancer as an example. Thyroid cancer we do very, very well with. Why? Because iodine is so specific for the thyroid gland. So we can bomb the body with radioactive iodine, and it'll just go to the thyroid gland, and it'll treat the tumor in there, leaving the rest of the body alone. Now, if we can find receptors that are specific for a tumor, and that we could do the same thing that we do for thyroid cancers, which are often curable these days. My wife's cousin is 28 years old with metastatic thyroid cancer. But I think she can have a pretty good chance to survive because of radioactive iodine.
Now, I think saving your tumor, which I was never aware of, saving your tumor tissue and having it frozen, the live samples frozen, is to me, if I need surgery and it recurs again, I think that's promising for the future. So it would be an individualized basis for treatment, depending on my own tumor.
Right. I mean, we haven't found those receptors yet. We haven't found the signature for every single tumor. And like I said before, I think GBM is going to be many different types of tumors in the future. Now, is each type going to have its own fingerprint to it? I don't know. But that's where a lot of the molecular treatment and diagnostic efforts are aimed at in the near future. If the last diagnostic jump was MRI, I think the next diagnostic jump is going to be molecular imaging.